Hi, I'm Elaine. I'm the Chief of Service at the Department of Radiology, Hong Kong Children's Hospital. In this presentation, I'd like to share with you on MR safety perspectives from Hong Kong Children's Hospital. I have no disclosure. Hong Kong Children's Hospital is a fairly new hospital. We were born in December 2018. The Department of Radiology houses CT, MRI, angiography, fluoroscopy, ultrasound, in addition to general radiography. In this presentation, I'd like to share with you our experiences on commissioning, equipment, zone implementation, workflow creation, guidelines, and training. On March 6, 2018, our 1.5 Tesla MRI scanner was delivered. Wall panels were purposefully built at this location to allow for installation. They were removed. At 6 a.m., the magnet arrived. It weighed 4,500 kilograms, and it is through this wall panel that the MR was delivered. Once MR is installed and our magnet was ramped up, we implemented zoning. MRI suite is divided into 4 zones. Zone 1 is MR access area, which is a public area. Zone 2 is MRI patient screening and preparation area. Zone 3 is a restricted access area, which is a control room. And Zone 4 is restricted access area, which is the magnet room. So here's our Zone 1, which is our corridor and waiting area outside MRI. Zone 2 is our patient preparation area, where we prepare the patient, including changing into patient gown, completion of consents, patient MR safety checklist, screening with wall-mounted ferromagnetic detection system, and a handheld metal detector. Zone 3 is our control room. Here we have the pillar-type ferroguard to screen patients as well as staff. Zone 4 is where the scanner is housed. Regarding equipment, we are very much aware of the risk association, as there are multiple devices that can be brought into Zone 4. Devices that belong to radiology, as well as devices that belong to our team of anesthesiologists who perform our sedation. A good understanding of MR safety labeling is essential during equipment procurement, as well as during daily operation. MR unsafe items should not enter the MR scan room. Patients with MR unsafe devices should not be scanned. MR conditional items may be safely enter the MR scan room only under very specific conditions provided in the labeling. Patients should not be scanned unless the device can be positively identified as MR conditional and the conditions for safe use are met. The conditions for safe use will be different based on the intended use of the device. For items intended to enter the bore of the MR system, the MR safety labeling should be matched with the MR safe system for static field strength, maximum spatial field gradient, SAR limits, etc. Items not intended to enter the bore of the MR system usually have Gauss line positioning restrictions or requirements to tether or affix the device to an unmovable part of the room. MR safe items pose no safety hazards in the MR environment. They may be placed anywhere in the MR environment. Patients with MR safe devices have no scanning restrictions. These are the items we commonly use. For example, we have MR safe wheelchair. Our physio monitor is also MR safe, and these equipment can be brought into very close to the MR bore. However, we need to observe the 150 Gauss line when using our ventilators. In addition, there are other equipments that ensure patient safety while in the scanner, for example, safety belts, CCTVs, alarm belts, and we also have an MRI compatible incubator. Next, we will talk about workflow creation. Clear role delineation is essential. MR team is made up of radiologists, radiographers, and nursing staff. Each discipline has a unique role and each step of the MR procedure. For example, In MR request vetting, radiologists and radiographers have roles. Radiologists should understand that the patient is clinically indicated for MR. The questions of how old and if sedation is necessary should also be asked. At Hong Kong Children's Hospital, we're privileged to have supportive sedation service. Our anesthesiologists provide a lean sedation service. For our outpatients, when patients are referred for radiological examinations and deemed requiring sedation, they are referred to the same-day pre-sedation assessment. When patients come for radiology exams, they come straight to our department without the need for admission. Our anesthesiologists sedate them on site, and patients wake up in our recovery room and go home from our department. For young babies aged 0 to 6 months, we can use the feed and sleep method, and sedation may not be necessary. These patients are also seen at pre-sedation assessment. The parents are briefed about the preparation, and on the day, the babies come after some sleep deprivation. Once they are fed, we wrap them up nice and warm, and we scan them as they fall asleep. We are also strong believers in engaging and empowering the child and parent. So we have in-house produced age-appropriate education videos and storybooks. We also encourage parents to watch our introductory videos with their children. In pre-COVID era, we have angioplay specialists to conduct play scanning using our MR simulator. With all these initiatives, we found that we could effectively reduce anxiety and build trust and confidence in our young patients. For inpatients, we have pre-exam safety checklists for our ward staff to complete. This is to ensure that all equipment the patient is connected to are able to enter Zone 4 safely. Our radiographers would also vet our MRI forms weeks ahead of the scheduled appointment. This would be repeated when the patient attends the actual appointment. They would check for patient's medical history and for presence of implants and foreign bodies. They will sort out the model, nature, and location of the devices, clarify the MR safety status, and also check the accompanying persons when they arrive. MRIsafety.com is a handy website for device checking. We also have our own archive of commonly used devices by our clinical colleagues. We are cautious with implants and devices as they pose safety risks, for example, with heating, dislodgement, and dysfunction. They may also affect image quality, leading to magnetic field interaction, blooming artifacts, and misregistration. Some of the commonly encountered implants and devices in our department are programmable shunts, feeding tubes, cochlear implants, and braces. Pre-scan preparation also include equipment check based on principles I mentioned earlier. As for patient and accompanying persons, if they enter Zone 4, they are all screened by various detection systems I presented earlier. Inside the MR ball, we apply hearing protection. We also have a squeeze ball device for our children to alert our radiographers during scanning. There are special considerations for certain units of the hospital. For critically ill patients from the ICU or cases that may be transferred directly from operating theatre, I cannot highlight enough the importance of screening of equipment that are brought in, as well as screening of the escorting staff. I'd also like to mention the danger of thermal burns due to improper patient positioning and improper use of equipment, for example, cable looping and unsafe biomedical devices. Since the interaction between the metal probe or wire loop and the magnetic field can result in high thermal conduction, full thickness burn can occur over the entire body surface during MR exams. RF heating and burns can be prevented through proper patient positioning and use of insulation, like using pads. From time to time, thermal injuries have been reported. Here is a case of full thickness burn arising from the left earlobe in a 2-month-old child caused by high conduction heat from pulse oximeter metal probe that was placed at the earlobe. As for MR guided procedures, we have a fairly elaborate preparation process whereby our MR and IR teams meet and go through step by step the procedural plan, including patient history, the procedure, patient positioning, step-by-step of the interventional procedure and how the patient is transferred, the equipment that is being used, the MR scan protocol, as well as in case of needle repositioning or resuscitation is necessary, how to place the patient. After the exam, checking of some devices may be required. For example, we have a collaborative workflow with our neurosurgeons on checking and adjustment of programmable shunts. Last word on workflow creation is on infection control measures. Based upon standard designs, MR rooms and corresponding control rooms have positive air pressure, forcing bulk air out of the MR area without allowing it to circulate back into their room. This reduces particle accumulation on all equipment in the MR room. However, this can theoretically lead to transmission of airborne pathogens into Zone 2. The current guideline recommends the minimum application of 6 air changes per hour in hospital setting to prevent infection spreading in the healthcare facility. For aerosol generating procedures, increasing the air changes to 12 per hour is recommended. A 60-minute aeration time followed by a standard disinfection protocol in an MR room is recommended as well after contact with a COVID patient. All the department staff should adhere to personal protective equipment guidelines at all times. Lastly, on training, at Children's Hospital, training is required for all staff who may gain access into the MR magnet room, meaning Zone 4. Compulsory training for all supporting staff who will perform cleansing in the MR suite is required. We have regular training sessions to NICU and PICU colleagues, and we hold regular MR safety forums. There are many international guidelines that could be referred to, including guidelines from the American College of Radiology. There's the ACR manual on MRI safety, which contains a small proportion on pediatric safety. It is key that the entire MR team is familiar with all these guidelines. To conclude, I'd like to thank you for giving me this opportunity to share with you our experience in commissioning. In the last 15 minutes, we've looked at equipment, zone implementation, workflow creation, some guidelines, and training. As I end, I'd like to highlight that teamwork is the key to enhancing MRI safety. I'd like to take this opportunity to thank my team of radiographers and fellow radiologists.